Sleep-related hyperhidrosis is defined as sweating during sleep that exceeds the body's requirements for normal temperature regulation. This often results in soaked clothing and bedding, causing significant sleep fragmentation for the patient. Clinical monitoring reveals a sudden, intense onset of physiological heat that forces an immediate spike in heart rate. This sympathetic surge drives the eccrine glands into maximum production, abruptly pulling the brain out of its sleep cycle. Patients frequently attribute this to environmental factors, such as an overactive heater or heavy blankets. However, these episodes typically persist even in cool environments, indicating a failure in internal autonomic regulation. These localized sweating responses provide a direct, observable data point on the state of the autonomic nervous system, revealing internal stressors that remain hidden during waking hours. Under normal conditions, the body's core temperature drops as sleep begins. Heat loss mechanisms activate to facilitate this cooling, maintaining a stable baseline through mild, imperceptible perspiration. This stability changes during REM sleep. As shown here, the brain's ability to actively regulate body temperature is impaired, creating physiological vulnerability. Because normal sweating responses are altered, any pathologically driven heat production becomes highly noticeable, amplifying underlying issues. This shift turns the REM phase into a physiological stress test, unmasking systemic pathologies that would otherwise be managed by the body's daytime regulatory systems. Governed by the hypothalamus, the brain's temperature control center sends false physiological signals when dysregulated, behaving as if the body is in extreme heat. This triggers a neurological surge traveling through the brainstem, forcefully activating peripheral sweat glands. When no medical cause can be identified for this activation, it is classified as primary or idiopathic hyperhidrosis, a chronic condition that is often localized. More common is secondary hyperhidrosis. This form is a symptom of an underlying medical condition, requiring a systematic clinical investigation to identify the root cause. Excessive sleep sweating is a physical indicator of systemic biological stress, triggered by these neurological pathways. Obstructive sleep apnea provides the clearest model for how mechanical issues create secondary autonomic responses. Recurrent airway collapse causes hypoxia, an oxygen drop interpreted as life-threatening. To restart breathing, the brain triggers a cortical arousal, forcing a transition to lighter sleep. Repeated arousals generate massive sympathetic surges, spiking heart rate and forcing sweat glands into active secretion. In a sleep lab, clinicians observe these physiological arousals on a Macaulay graph in real time, seeing the direct connection between breathing struggles and autonomic spikes. When the mechanical obstruction is resolved, typically through CPAP therapy, the sympathetic surges stop, and the night sweats often disappear entirely. This model proves that a localized physical blockage is capable of creating a generalized autonomic crisis. The differential diagnosis includes chemical disruptors. Hormonal fluctuations during menopause or thyroid disorders alter temperature thresholds. Medications like antidepressants and antipyretics interfere with neurotransmitters managing autonomic pathways. Beyond chemical and mechanical issues, night sweats are a long-standing clinical indicator of severe, chronic systemic infections. Tuberculosis is the classic historical example. The disease's impact on the immune system frequently manifests as severe sweating episodes during the night. Malignancies, particularly lymphoma, present with a specific pattern of drenching sweats, recurrent and severe enough to require completely changing clothing and bedding. In these contexts, recurrent night sweats manifest as the external physical result of hidden chronic infections or malignant cellular growth. Clinicians use a diagnostic decision tree to separate primary cases from secondary cases requiring intervention. The routine branch screens for sleep apnea via polysomnography and checks thyroid function for hormonal imbalances. An urgent branch activates when red flag symptoms accompany the sweating. These red flags include unexplained weight loss, persistent fever, and lymph node enlargement. Their presence necessitates immediate screening for cancer or chronic infection. Finding any of these indicators shifts the clinical focus from sleep quality to aggressive diagnostic testing for systemic disease. Managing the environment with moisture-wicking clothes and cooler room temperatures is a secondary, palliative step. While these measures improve comfort, they do not address the biological driver of the sweat. Effective management requires treating the underlying pathology. Primary hyperhidrosis is managed through symptom control, but secondary hyperhidrosis is only resolved by curing the cause. This highlights the need for a rigorous clinical evaluation. Accurately diagnosing the cause requires a detailed review of the patient's physiological records to identify the exact moments of autonomic stress. Chronic sleep-related hyperhidrosis signals significant sleep fragmentation or underlying systemic disease. By understanding these autonomic pathways, clinicians can use a patient's sleep symptoms to uncover and treat serious medical issues.